This is Dr. Bernstein with the February 2017 Teleseminar. Before we begin, I want to give you our usual warning that my answers to your questions are general answers. They cannot necessarily be accurate specifically for you because I haven't examined you, I haven't gotten your complete medical history, and the purpose of this seminar is for the bulk population of listeners to give them an education. So I may answer your question and give a good education to the listeners, but it might not be the real solution to your problem. Before we proceed, I want to mention that I stumbled upon a new finger sticker for blood sugar measurement that I like very much. It's painless and manages to get through the calluses on my fingers. It's called True Draw, Truedraw, made by Nipro. I purchased a load of them from Amazon, but there may be many sources for these. They're inexpensive, cost me about $6. We have two special subjects this week. The first relates to the use of insulin pens. Now, insulin pens have advantages and disadvantages. The advantage is that you don't have to go through the trouble of filling a syringe from a vial. A disadvantage is that you cannot get half-unit measurements with insulin syringes, and for most children, you need half-unit measurements. Another problem is that you cannot get diluted insulin through insulin pens. So those are two problems. The third problem is that the needle is very short, I believe about 6 millimeters. So sometimes you may get leakage from such a shallow injection. Now, most people do not use insulin pens properly. And in particular, I'm thinking about how long you'll keep the needle in your skin holding down the button, and then later when you release the button. What I find is that I have to hold the button down during an injection. I push when I throw in the needle, then when the needle's fully into my skin, I push the button down and I hold it down for 10 seconds, but seconds are hard to count. So what I do is I count to 20. And then after you release the button, you have to leave it in for another 10 seconds. So I count to 20 again, slowly. And even then, sometimes I get leakage. But at least I'll do much better by doing those 2 20-second intervals rather than pulling it out rapidly. And as I said, most people don't wait, as I explained. The next problem that I want to discuss, subject number 2, relates to taking insulin when you go out for a meal, when you're going somewhere else. Many of my patients actually take coolers with them, a vial of insulin, and then at the table or at the restaurant, they take the insulin out of the cooler and draw their dose out of a vial, and so on. A lot of unnecessary work. What I do, first of all, one vial out away from home for a few hours is not going to be harmed. But if you're getting very small doses, for example, let's say you only take 2 units for a meal, there are 1,000 units in a vial of insulin. That would be 500 meals. So you're taking this whole vial away from the refrigerator for maybe many, many hours over the course of a year, the insulin might deteriorate. What I do is I pre-fill 2 syringes, one with a little more than the dose I expect to need, and in the restaurant I'll squirt out the excess. Why do I bring a little more? Just in case I expect to eat more than usual, which I rarely do, but just in case I have a little extra there. And I take a second syringe filled the same way, just in case something happens to the first syringe. It's not really necessary. I've never really needed the second syringe, but I don't trust myself. I stick 2 syringes in a jacket pocket, but sometimes I lose things, and I'm playing it safe. Now, the little bit of insulin that you have sitting in the syringe that's going to be away from a refrigerator for a few hours is not going to be harmed. The problem is if you take a whole vial and keep that whole vial out of the refrigerator and then do this hundreds of times with the same vial, then the insulin might deteriorate. So pre-fill the syringes. If you want, you can purchase a pre-filled insulin syringe container, which is about the size of a pen, and you drop the syringe in this container. I think it has a pocket clip on it like a fountain pen, and it preserves the setting of the syringe. So even if you bump the box, the setting on the syringe won't be disturbed. Okay, now with the first question. For patients with type 2, what do you think begins to cause damage to the vagus nerve and blood? No, what A1C do you think begins to cause damage to the vagus nerve and blood vessel damage? Well, any of the damage caused by elevated blood sugars occurs over time, and a high blood sugar for a relatively short period of time, maybe a year, very high blood sugar for a year, maybe even less, can cause damage, and a slightly elevated blood sugar for many years can cause damage. So I have a friend who is not a patient of mine. She has what's called sympathetic neuropathy. Her feet cannot sweat. She has dry, scaly feet, and she craves sweets, eats a lot of sweets, not a known diabetic, and she's developed sympathetic neuropathy. She also has other problems suggestive of elevated blood sugars. Her A1C is only slightly elevated, 5.4%, which is an average blood sugar of 116 milligrams per deciliter. So this very mildly elevated blood sugar could be tens of years has caused damage. So we can't say a fixed A1C for a certain period of time. We can say that the product of blood sugar and time adds up, and that's basically it. Can there be a thyroid diabetes connection if my average fasting blood sugars are 117 milligrams per deciliter? The thyroid disease that we see with diabetics is principally caused by inheritance, just as the diabetes is. As I've said before, autoimmune disorders come in clusters. You rarely get one autoimmune disease. I have, I think, something like 6 or 7 different autoimmune disorders. And by the way, the most common one to come with diabetes is psoriasis. My psoriasis preceded my diabetes by about 10 years. My hypothyroidism came after the diabetes. One did not cause the other. So you can't say that a certain blood sugar is going to cause hypothyroidism. Now, it can be that diet and blood sugar affect your serum free T3 levels, that is the conversion of the T4 thyroid hormone, the major thyroid hormone, to the active hormone T3, can be affected by diet, can be affected by blood sugar, but does not cause hypothyroidism. Hypothyroidism occurs when the thyroid gland is not making enough hormone. Anyway, we'll get on to the next question. Type 1 diabetes for 6 years, 22 years old. No damage yet. Please suggest what can be done in the way of specific yoga or exercise that can control the blood sugars. Well, here again, we're running into someone who's expecting magic to cure their diabetes or to improve their blood sugars. It's true that strenuous exercise can lower blood sugars, but most of the lowering occurs at the time of the exercise. You're not going to control or normalize blood sugar with yoga or exercise. You need insulin. This person should read my book, Diabetes Solution, and follow the regimen for type 1 diabetics. Next question. My 8-year-old son was just diagnosed type 1. He and his little sister have always been very skinny, around the 3rd to 20th percentile for their ages, but average height. Do you have any recommendations for helping them fatten up, even while we follow low-carb recommendations to normalize blood sugar? Again, read my book, Diabetes Solution. Basically, we don't try to fatten people up. We try, if their weight is low, we try to increase their muscle mass. And we do that with insulin and protein. So you give these kids a high protein diet and enough insulin to cover their protein at their meals so that their blood sugars don't go up. And insulin is an anabolic hormone. It will build muscle mass if you give enough protein with it. Next question. What is the reason and need for B vitamin shots? Are there any other critical vitamins that a type 1 diabetic would need to take with your diet? Well, it's just the opposite. Type 1 diabetics, for the most part, are very poorly controlled, and especially those who are taught to follow ADA guidelines, which require very high blood sugars and high carbohydrate intake. The high blood sugars cause you to urinate a lot, and you're going to urinate water-soluble vitamins, and the B vitamins are water-soluble vitamins. So if you make a type 1 diabetic poorly controlled, if you raise his blood sugars, he's going to lose B vitamins. And I guess one way to replace them is to give shots. But if a person is on the regimen of my book, Diabetes Solution, you don't need supplemental vitamins. We're giving adequate, our dietary guidelines have vegetables, and we recommend some red meat. We recommend other proteins. So we should not be malnourished. I've gone for 71 years with type 1 diabetes, and the only time I was malnourished was when I was on the ADA diet some 50 plus years ago. I remember dentists would look at my gums and say that I was malnourished. The gums have much improved since I've had normal blood sugars. So if you follow the ADA regimen, as I did, you'll probably be missing some water-soluble vitamins. But if you follow our regimen, that shouldn't happen. I've been diabetic for 8 years and take metformin at a low level each day. My iron levels have been declining over the past 8 years, and now I have mild anemia. I wonder whether the decline has been caused by metformin and what I can do. Well, first of all, we don't check serum iron levels to determine the body iron stores. We look at serum ferritin, Ferritin. That's an indicator of total body iron scores. Also, total iron binding capacity, and perhaps a few other tests, but not serum iron levels. So, for all you know, you may have normal ferritin. To my knowledge, it's not caused by metformin, although metformin can impair the absorption of vitamin B12. If you're on a diet that excludes red meat, it could be that your ferritin levels are low. That's about all I could say. I don't think the metformin caused it. Is it possible that Lantus can contribute to cancer of the thoracic spine? I guess it's possible. I don't recall that the statistics that we got from Europe a number of years ago from several national databases of that covered Lantus users. I don't know that any mention was mentioned of cancer of the thoracic spine, which is pretty rare. So I doubt that there's literature out there that would support this. We do know that cancer in general seems to be at a much higher rate in Lantus users based upon some international studies. What is the best way to control the dawn phenomenon for a type 1 and a type 2 not on insulin? Again comes my book. Basically, we have several approaches. One approach is taking a long-acting medication at bedtime, like Tresiba insulin, if you're taking insulin, or maybe Glucophage XR, or Glucophage XR plus Avandia if the XR alone is not enough. Another approach is to take rapid-acting insulin on a rising just before the blood sugar goes up. And there are probably a variety of other tricks that you can use. For example, one trick for type 1s is to take Levemir insulin, one shot at bedtime and another shot about 6 hours later. So if you happen to get up 6 hours after you go to sleep or set an alarm 6 hours later, that's one way around the dawn phenomenon. And basically, it's whatever works is what you should do. And there are a lot of tricks that you can look into. I would like to get an RR interval study done. I've asked my family practice doctor, endocrinologist, and cardiologist, and have no luck getting one done. I live in Pennsylvania. It's very hard to get RR studies done. I do it on every patient. We've been talking about maybe doing it as a service for non-patients. There's the problem of liability. do you become a treating physician if you do this test for somebody? And then if you don't continue to treat the patient, are you responsible for what happens to him? I don't know of any doctors anywhere who do the RR interval study routinely. Many research labs all over the world do it. It's a standard test for autonomic neuropathy. And probably should be done if a patient has erectile dysfunction to see whether it's neurologic or vascular. You'd also do penile blood pressures. It would help tell you in advance if a person has gastroparesis, et cetera, et cetera. I've published a protocol for doing RR studies. Sometime down the road, if I can get another physician with a camera to come in here and film me doing RR studies, I'll teach it over the internet. But right now, it's very difficult, and I don't know how you can get it. You can look on the internet. There are some naturopaths that are doing it, but they're selling products to go with it. So there's sort of a strange scheme going on where RR studies are used as an excuse for selling supplements. Here's another one. Type 1 for 46 years. So this person is a survivor. There are not many of those around. On your program, caught a cold and BGs have spiked erratically for about 18 hours, and my usual ratio of 1 unit Humalog for 50 milligrams above target keeps blood sugars at 120 to 175. What is your recommendation for increasing the corrective insulin ratios or adding another insulin? This person says he's on my program, but it doesn't look like he's read my book, Diabetes Solution. This whole ball game of how much insulin you take to lower your blood sugar, how much, if you have a cold or an infection, is all trial and error, very individualized. You have to know how to do experiments. So, and the best time to do these experiments is when you're not eating. So, if you want to go to bed, not eat overnight, have an elevated blood sugar in the morning, correct it with a guesstimate of how much insulin you need, and then measure your blood sugar, say, every hour, and see what happens. Let's say 1 unit lowers you by 50 over the course. This is Humalog, so let's say you check for 6 hours. Even though the Humalog may last longer, most of its action is done in 6 hours. Check it every hour for 6 hours, and you'll find out how much you dropped. Another thing to remind you about is not to get colds, to take Sambucus lozenges whenever you're exposed to the possibility of a cold. So I try to teach my patients, if they're going into a crowded room for a meeting or a movie or a show, take Sambucus before you go in. If you're going on an airplane, take it, and if it's a long trip, take it every 6 hours during the trip. If there's someone else in the house who's sick, you take it. If kids in your child's school are sick, take the Sambucus yourself, because sooner or later your child's going to come home from school, maybe sick, et cetera, et cetera. Of course, your child should take it if he's going to school and there are sick kids in his class. Type 1 son, 8 years old, randomly tested ketones. One morning he didn't eat and ketones were so-and-so. BG was about 78 milligrams per deciliter. Should adjustments be made? Question is, why on earth is this person testing for ketones? This is a habit that endocrinologists have imposed upon patients, which is totally unnecessary. Fasting humans make a lot of ketones. The history of humanity is one of feast and famine. And during famine, the ketones have kept humans alive. They're essential for life. They're good for the brain. We find that ketosis is a tool for preventing seizures in epileptics. Ketosis is currently being used experimentally for the treatment of Alzheimer's and other brain disorders. So there's nothing wrong with having ketones in your blood. There's no reason for testing for them, except if you have very high blood sugars. And then you can go into ketoacidosis, which is a totally different state of very low serum pH. And it's mostly a dehydrative state, which is caused by vomiting, diarrhea, and very high blood sugars, where you pee away a lot of glucose and you also pee away a lot of ketones. Totally different situation. But endocrinologists have gotten in the habit of forgetting that ketones are beneficial. So there's no reason to be testing for them, no reason to be worried about them. I've had diabetes 71 years, and the last time I tested for ketones was when I was a child, when my blood sugars, as we subsequently learned, would go over 600 several times a day. And that's when I was on the ADA diet. Can fasting be part of your low-carb diet? Well, what's nice about my basal bolus insulin regimen for type 1s is that you don't have to eat meals. You could skip a meal and skip the insulin for the meal. But to routinely and deliberately fast doesn't make sense because it causes loss of muscle mass. And then when you start eating again, you rebuild fat before you rebuild muscle, and you may not even rebuild the amount of muscle that you've lost. So fasting is not a sensible thing to do deliberately. If you have to miss a couple of meals, or if you're sick and have vomiting or diarrhea and can't eat for a few days, you drink fluid and you don't eat, and that kind of fast is reasonable because you'll be less sick if you're fasting and vomiting. So that's basically my opinion. Type 1, 8-year-old son. Your book is really for adults? ? Absolutely not so. In fact, the first edition of my book was strictly for type 1 people because I didn't know anything about type 2 when I was in medical school and wrote the book. Now it's for both type 1s and type 2s, and certainly for kids. And we talk all about diluted insulin and so on. Is it safe to reduce his carb intake? How would I be able to go about it when my child is a picky eater? How do I have him snack or meal every 4 to 5 hours while in school? Well, first of all, where is he getting the carb from? If there's carb in the house, someone is buying it, and I doubt that he's going to the grocery store and buying it. One big problem that we see with kids that eat a lot of carbohydrate is that the parents are eating a lot of carbohydrate. In fact, I had one girl who was very compliant. She did what she was supposed to do, but she was very slim, and both parents were grossly obese. And when she got home from school at night, they would be sitting in front of the television, eating potato chips and pretzels and ice cream and whatnot, and I'm expecting her to follow a low-carb diet. Well, this particular young lady was a teenager, and she complied, but that's rare. First of all, the parents and the siblings should all be on low-carb diets for a variety of obvious reasons. You don't want the siblings to also get diabetes, and high carb could be enough to throw you over the line. And certainly you don't want to send a poor example for your kids. So that's number one. And certainly you should not be purchasing the high-carb foods. Where is he going to get it? Now, the next problem. Having him snack or have a meal every 4 to 5 hours. If he's on the regimen described in my book and is getting hungry, then you're going to have to let him have a snack. But he may not be getting enough protein at his meals to hold him to the next meal. That's one potential problem. The other problem has to do with ADA guidelines, where the most common ADA approach to treating type 1 diabetes is to give them 1 or 2 shots of long-acting insulin a day at very high doses, forcing them to eat all day long and snack all day long. So if that's what's going on, that's a problem. Use my book and follow the guidelines in the book. If on a rational meal plan he's still getting hungry, we have to include snacks, and we have to cover each snack with insulin. But the main thing is not to have high carbohydrate foods around. Next question. What is the proper procedure for measuring how much 1 gram glucose raises my blood sugar? I have the Freestyle Freedom Light meter you recommend. Well, I also recommend the Freestyle Freedom. And again, read the book, and that procedure is covered thoroughly in the book. I think I've already answered this question. Does erythritol in Truvia raise blood sugar? Probably not. Truvia is a sweetener that contains a mixture of stevia and erythritol, and except in very large quantities, neither of these should have a significant effect upon blood sugar. New type 2, lost 12 kilograms of weight, struggling to maintain a low-carb diet, taking 1,000 milligrams metformin twice a day. Blood sugars go up after meals as high as 150 milligrams per deciliter. Cannot exercise due to long hours at desk job and osteoarthritis. Well, before I even get to the question, I'm going to suggest that most people with arthritis have it in certain joints, but not in others. So let's say the person has arthritis in his hip joints and cannot do exercises that involve the hips? Well, he can do toe presses. He can do weightlifting with his forefoot, which I do, by the way. It's an oddball exercise, but I can take 2 feet and lift 100 pounds just by flexing my ankles, lifting my 4 feet. I could lift that 100 pounds about 45 times. So there are exercises that you can do that avoid the arthritic joints. If it's only your lower body that's affected with osteoarthritis, you can do exercises with your upper body. If it's only your upper body that's affected, you could do it with your lower body, et cetera, et cetera. If it's your shoulders, you could do it with your lower arms, et cetera. But let's get on to the question. What else should I do, and should I start insulin for my pancreas to rest and recover? My doctor refuses to order insulin. Well, if the person is really on a low-carb diet, and if he's really using my book, certainly insulin may be necessary, and insulin always works. And if your doctor refuses to order it, you can find another doctor. What I usually advise people to do is ask their friends and neighbors if there's a local family practice physician who is kindly and who listens to the patients. Most endocrinologists adhere to ADA guidelines and may be afraid to prescribe insulin for type 2s, et cetera, et cetera. How do I get my body to accept normal blood sugars? I was so used to having high readings that when my blood sugar gets a normal number, my body goes into a panic. Again, read my book, Diabetes Solution. And the game plan here is to taper your blood sugar down gradually. And when I get a new patient with, let's say, blood sugars running above 200, I might initially shoot for a target of, say, 170. And then after they're comfortable on that for a while, we'll go down to 150. And eventually, we'll gradually work our way down to our usual target of 83. You do it gradually, and that way you get used to it. The body gets used to high blood sugars when you've had them for months or years, and thinks that a lower but high blood sugar is hypoglycemia and behaves accordingly. How do I gain weight on a 6-12-12 diet of carbs? That's 6 grams for breakfast, 12 grams for lunch, 12 for dinner. As I've said repeatedly in my book, my teleseminars, my videos, it takes insulin and protein to gain weight in a healthy fashion. And if you're a type 1 diabetic, you add protein to your meals and increase the insulin dose for the meals. If you're a type 2 diabetic, you may or may not be able to increase the protein at your meals without insulin. And today, I spoke to several supposed type 2 diabetics who I'm giving small doses of diluted regular insulin or diluted Humalog insulin to cover their meals because we've added a lot of protein and they're gaining weight. From your, let's see, Tresiba works very well for me in leveling my blood sugar numbers. However, I've gained 16 pounds since I switched from Lantus. Would Byetta or Simlin help shedding the pounds without affecting my gastrointestinal system? I have Crohn's disease. Oh boy, this is complicated. Well, first of all, you should read my book. And one point that I'd like to make is that if you have historically had high blood sugars when you were taking Lantus insulin, you'll be peeing away calories and losing weight or not gaining weight. And then if you take Tresiba and your blood sugars are normalized and you stop peeing away glucose, you might gain weight. So you really have to very carefully follow the guidelines in the book. It could be that your doses of Tresiba are too high. It could be that you're above a basal dose, that you're forcing yourself to eat by having too much insulin on board. So it's a matter of trial and error. One way to find out if you're taking a true basal dose is not to eat all day and see what happens to your blood sugars when you're not eating. If you're taking the Tresiba insulin and you're dropping all day long, you know the dose is too much, that you're getting a super dose, not a basal dose. 55-year-old male type 2 on a very low carb diet, less than 30 grams a day, feel great, except for dizziness or vertigo, especially after I've bent over. I've tried salting my food and even taking salt tablets of limited benefit. Blood tests are excellent. No electrolyte or other issues. I've completely normalized my fasting blood sugars. Last A1C was 5.4. Well, true vertigo, which is spinning, the world seems spinning around you, and that involves dizziness, as opposed to lightheadedness. Lightheadedness is where you stand up suddenly and you think you're going to pass out. That could be due to low blood pressure, and sometimes taking salt water helps postural hypotension, which is what that's called. But true dizziness or vertigo is a totally different thing and does relate to position of your head and certain sudden actions of the upper body and so on. So if you have true vertigo, you have to see an ENT, ear, nose, and throat physician, who specializes in vertigo. And he has to work you up and figure out a treatment for this. And there are a variety of treatments, including medications, exercises, and so on. So if the world is spinning around, that's true vertigo. Do you think lemon vinegar and cinnamon lower blood sugar levels? Well, again, this is someone who's looking for magic to treat diabetes, and there ain't no magic to treat diabetes. Read my book, Diabetes Solution. My 4.5-year-old son was just diagnosed with type 1 diabetes a month ago. He is due for his final DTaP and polio booster vaccines in March. Should we be concerned about giving these both at the same time? About anything to watch regarding the blood sugar when giving a vaccine? Well, you don't have to be concerned about giving them at the same time. Some people can develop an inflammatory reaction to a vaccine. It's usually pretty rare. If you read my book, Diabetes Solution, you'll find out what to do if his blood sugars goes up, how to correct them, and so on. Not likely, but it's a possibility. If the blood sugars are elevated for several days, we usually increase the long-acting insulin. If they're just briefly elevated, we correct them with short-acting insulin, and that's all covered in the book. Okay. If basal insulin dosage is split, say evening dose at bedtime and morning dose at breakfast, how does the regimen entirely eliminate morning hypos when a dose has been taken at bedtime? If someone is getting morning hypos and doesn't know why, they haven't read my book. So I think that you ought to read my book, Diabetes Solution, and what happens to your blood sugars overnight depends on many, many things. Things like whether or not you have gastroparesis, what your blood sugar was at bedtime, how long was the time between your dinner insulin dose and bedtime, when you took your bedtime long-acting insulin, when you took the morning insulin. There's so many variables, but the book will help you. I'm 60-year-old male, 134 pounds, 5 foot 5 inches, eating low carbohydrate, high fat for 2 years. Again, I have to mention that there's this bizarre diet that's being recommended by people on the internet, low carb, high fat. And this is not what I'm recommending. I recommend low carb, high protein, and then not worrying about the fat. To deliberately load yourself with fat instead of protein just doesn't make sense. It's a good way to lose muscle mass. Anyway, waking blood sugar is 110 to 120. I eat early and not before bedtime. Just before lunch, 115 to 119. What else can I do to reduce blood sugars without medicine? Well, maybe there's a way by exercising, strenuous exercise, and building muscle mass. Otherwise, you probably need medicine. It looks like you're not overweight. Although I'm wondering, 5'5" is my height, and I weigh 110, and I'm solid muscle. So it could be that this man is overweight, has abdominal fat, and possibly, certainly by building muscle mass and losing fat mass, he might be able to get away without medication. And he should read my book, Diabetes Solution. My mother died of pancreatic cancer at age 70. Should I be afraid to take Tradjenta and metformin? Type 2 diabetic. Well, Tradjenta is sitagliptin. It has nothing to do with pancreatic cancer. It's not like Lantus insulin. And metformin has nothing to do with pancreatic cancer. In fact, there are some studies that show that it reduces the incidence of cancer. So he says that his A1C is 7.4, which is an average blood sugar of 196. And I would suggest that you get your blood sugar way down, read my book, Diabetes Solution. Having such high blood sugars is going to wreak major havoc in your life sooner or later. I'm a 42-year-old woman who got diagnosed with type 1 2 years ago. I've been eating low carb and it works wonders. I don't have to take any Humalog. Question is what to eat when I get low blood sugars? Well, first of all, if you're really a type 1, you need insulin. If you're not taking any insulin, I find it hard to believe that you're type 1. I would suggest that you read my book, Diabetes Solution. And what I recommend for low blood sugars is either glucose tablets or glucose liquid. And it tells you how to dose it in the book. And read the book, Diabetes Solution. I've used Lantus for about 8 years for my long-acting insulin. Would you continue to use this type of long-acting insulin or switch to another like Tresiba? Again, read my book, Diabetes Solution. I like Tresiba very much because it circumvents the dawn phenomenon for many type 1s and also for type 2s. Not always. Sometimes some type 1s still have to take a shot of rapid-acting insulin on arising in the morning. But for many, taking Tresiba both morning and bedtime circumvents the dawn phenomenon. I'm trying to reduce my out-of-pocket diabetes costs. I have a friend who gets her insulin from Canada. Is this legitimate? Is the quality okay? If you purchase from a pharmacy that has a physical location in Canada, there shouldn't be any problem. If you're purchasing from a pharmacy who only has an internet location and a mysterious office somewhere, there may be a question as to what you're getting. But if you were to go to Canada and make a purchase from a pharmacy, there shouldn't be any problem. Or if you have a friend who lives in Canada, can buy the insulin at a pharmacy and ship it to you, should be no problem. If you can get a regular pharmacy to mail you insulin, no problem. What is the best way to find out if you are a type 1 or a type 2? It's interesting that just last night I read an article in the journal Diabetes indicating all of the different tests that are being investigated to distinguish type 1 from type 2, and pointing out that it's really a subjective determination, that different doctors or researchers or whatever are using different guidelines to make the distinction. And I've already said that diabetes is a continuum, that at one extreme, there's very mild diabetes where the patient is insulin resistant, making a lot of insulin, usually obese. And at the other extreme, there's this slim person who makes absolutely no detectable insulin. And that's clearly type 1 diabetes. And then in between, it's a matter of subjective opinion. And that's why I say, don't give the diabetes a name. Just treat the blood sugars and do whatever it takes to get normal blood sugars. I have people who are classified, who have been called type 1s, who do well on a combination of insulin plus metformin because maybe they're type 1s who are overweight and insulin resistant. Likewise, type 2s who may absolutely need significant amounts of insulin. Just do what it takes to control the blood sugars. Don't worry about the name. It's very hard to figure things out. You could use the C-peptide test, fasting C-peptide, no, not a fasting C-peptide, C-peptide after a meal. have a big meal, check your serum C-peptide level, and if you have zero C-peptide, no detectable C-peptide, which is a measure of how much insulin you're making, you're type 1. Or you're a person who was type 2 years ago, burned out his beta cells and became a type 1. Other than this, don't worry about it. Type 1, following your book with spectacular impact on blood sugar levels, our endo in Belgium is strongly pushing back, saying that hyperketonemia increases oxidative stress, which is a problem in the long term. Is this really dangerous? Well, I've been through this before. Mankind survived because of hyperketonemia during fasting or during famines. Ketones keep humans alive, and hyperketonemia is now being used to treat a number of brain disorders. Can you distinguish the differences between saturated and good fats and how they can affect blood sugars? Well, I don't know what are good fats. I don't manage to look at the different kinds of fats that I eat. I eat whatever comes along with the protein foods that I eat. I had a coronary artery calcium score done a few years ago, and after 71 years with type 1 diabetes, I had a calcium score of 1. The score can go from 0 up to maybe 15,000 or 30,000, and I had a score of 1. And I don't think that the fats that I eat had anything to do with this. It was the nearly normal blood sugars plus strenuous exercise that I think made a difference. There's no reason to look at different kinds of fats. I don't know about good fats and bad fats. There is some scientific evidence that certain trans fats may be harmful, but there are other trans fats that are beneficial. So like, as I recall, coconut oil may be a trans fat, but it may also be beneficial. Can Afrezza inhaled insulin be effective for type 1s or type 2s? Again, read my book, Diabetes Solution. We go into this. Inhaled insulin is not absorbed from dose to dose in a predictable way, on the one hand. On the other hand, it works very rapidly to lower blood sugar. So, if you were a very mild type 2 diabetic and your blood sugars went up slightly after a low carbohydrate meal, maybe a puff of a little bit of Afrezza might help keep blood sugars from going up. Trouble is, you don't know how much each puff is going to lower you. So that's basically it. Certainly would not use it for type 1 diabetics because you need real precision in treating type 1 diabetes. Well, that's it for tonight. Our next teleseminar will be on Wednesday, March 29th, 2017. Thanks so much for listening. See you then.